Equinus, Biomechanics by Patrick A. DeHeer, DPM. Disclosures. I am a principal of IQ Med. I am the inventor of the EQ-IQ brace. The Equinus dilemma. You are not paying enough attention to it. Root et al. Described Equinus as the worst foot in the world is one with the fully compensated Equinus deformity. Johnson and Christensen described Equinus deformity as the most profound causal agent in foot pathomechanics and is frequently linked to common foot pathology. And Hills described Equinus deformity as extremely prevalent, and it appears to be a primary causal agent in a significant proportion of foot pathology. So Equinus is extremely common. It's related to a lot of the things that we treat, and in order to fully understand it, we have to come back to biomechanics. Biomechanics can be quite challenging, but the way this lecture is broken down hopefully will make it easier for you to appreciate the biomechanics of Equinus and therefore understand the importance of treating it. Equinus biomechanics overview. Specific muscular function, Equinus compensation, balanced standing, subtalar joint axis and Equinus relationship, and literature review. These are the topics we're going to cover in this lecture. Triceps surae function. Root's 7 gastrocnemius functions. Root described the 7 functions of the gastrocnemius muscle. Number 1, to maintain flexion tension on the knee during late contact to late mid-stance. Number 2, to stabilize the knee, which prevents hyperextension. Number 3, to decelerate subtalar joint pronation, which occurs at the end of contact phase. Number 4, to accelerate subtalar joint supination, which occurs at mid-stance and propulsion. Number 5, to lock the mid-tarsal joint, which allows for subtalar supination and mid-tarsal joint supination. Number 6, to aid in lifting of the heel and knee flexion to initiate propulsion. And number 7, toe clearance, which is continued knee flexion during the first half of propulsion. Root's 5 Soleus functions. Number 1, to stabilize the lateral forefoot, which occurs in late contact and throughout mid-stance. Number 2, to decelerate pronation at the end of contact. Number 3, to decelerate knee flexion, which occurs at mid-stance. Number 4, to decelerate tibial forward momentum, which occurs at mid-stance. Number 5, to assist in heel lift, which stops ankle joint dorsiflexion during propulsion. Triceps surae function during gait. Gastrocnemius complex during gait. In stance phase, a maximum ankle joint dorsiflexion of 8 to 10 degrees is required just before heel off when the knee is close to full extension, stretching the gastrocnemius muscle, and the hind foot is normally supinated to create a rigid lever for propulsion. And this has been referenced in several articles in the literature. Therefore, for a normal step to occur, as your body moves over your foot that's planted on the ground, your ankle joint has to bend approximately 10 degrees to move your body from behind your foot over the top of your foot and forward right before heel off. Gastrocnemius complex during gait. Tightness of the gastrocnemius muscle limits normal advancement of the tibia relative to the foot during the mid-stance phase of gait. This results in a compensatory dorsiflexion of the midfoot, which we will discuss later in this lecture. Gastrocnemius complex during gait. For tibial advancement when ankle joint is limited, compensatory movements at joints proximal or distal to the ankle may occur, including the subtalar joint and mid-tarsal joints, and references for this are shown on the slide. Continuing gastrocnemius complex function during gait. With subtalar joint pronation, the talonavicular joint and calcaneal-cuboid joint axis, the mid-tarsal joints, are positioned more parallel to each other, allowing a more mobility to occur at the midfoot, which is the unlocked position of the midfoot, which this in turn reduces the rigid lever component of the foot that is required for propulsion. The picture on the right shows the alignment of the talonavicular joint and calcaneal-cuboid joint axes and how during pronation they become into a more parallel relationship instead of the more oblique relationship that occurs in a neutral position foot structure. Subtalar pronation during weight bearing results in dorsiflexion of the ankle joint, subtalar joint, and mid-tarsal joints to compensate for limited ankle joint dorsiflexion just prior to heel off. Excessive subtalar joint and mid-tarsal joint pronation, the theorized mechanism by which limited ankle joint dorsiflexion contributes to lower extremity cumulative trauma injuries, as shown by these articles listed on the slide. And pronation due to equinus causes excessive stress on the plantar fascia, which has also been described in the literature. Pronation due to equinus increases the eccentric contraction of the soleus and posterior tibialis muscles, causing medial tibial stress syndrome, also described in the literature. Equinus compensation distally. In the uncompensated equinus deformity, there is no heel contact to the ground, and that results in the toe walker. This is often seen in newborn infants who are just beginning to walk. It's the most common time that we see a toe walker. The partially compensated equinus deformity shows the heel contact to the ground, but the tibia is less than 10 degrees to the floor. This results in increased forefoot pressures and early heel off during gait exam. The fully compensated equinus deformity, the heel is contacting the ground, but the tibia is greater than 10 degrees to the ground. This results in a severely pronated foot with normal heel off. Equinus compensation proximally. Proximal compensation can result in lumbar lordosis, hip flexion, genu recurvatum, hamstring contracture. The picture on the right shows an extreme case of genu recurvatum that can often be associated with proximal compensation for equinus deformity. The relationship between equinus and the subtalar joint. Understand this and you will understand the effect of equinus on the foot. How does balanced standing occur? Ankle joint gastrocnemial moments. First, Olipa et al. In Spine in 1988 and Bajman and Stecco in JBJS in 1963 described the relationship of the center of pressure in the foot as it relates to balanced standing. The picture on the right shows the normal center of pressure, which occurs approximately 6 centimeters anterior to the ankle joint. Ground reactive forces create ankle joint dorsiflexion moment, which is balanced by this. The gastrocnemius complex creates an ankle joint plantar flexion moment, and those two balance each other out, and that's how you result in balanced standing. So to summarize and to understand this basic point, the normal center of pressure is approximately 6 centimeters anterior to the ankle joint, which ground reactive forces will create a ankle joint dorsiflexion moment pushing up on the foot. The gastrocnemius complex at the back of the ankle joint creates a plantar flexion moment which counteracts the ground reactive forces, ankle joint dorsiflexion that results in balanced standing. Normal subtalar joint axis, subtalar joint supination moment. Because of the insertion of the Achilles tendon medial to the subtalar joint axis, it creates a supination moment. With gastrocnemial contraction, the center of pressure moves anterior. When the subtalar joint is pronated or a pronation moment occurs, the center of pressure not only moves anterior, but it also moves lateral to the subtalar joint axis. A counterbalancing occurs in a normal subtalar joint axis position with the supination moment that occurs from the contracture of the gastrocnemius complex versus the anterior placement of the center of pressure that occurs with normal subtalar joint pronation. So if you look at this diagram on the right, you can see the center of pressure is approximately the same distance from the subtalar joint axis as the insertion of the Achilles tendon into the calcaneus. Therefore, they counterbalance each other. This is in the normal subtalar joint axis. So the center of pressure moves distally with pronation and laterally a little bit. The Achilles tendon is inserting medially. The distance between these two areas is approximately the same distance to the subtalar joint axis. Therefore, they counterbalance each other. There's no excessive pronation or supination occurring on the subtalar joint because of this. In the medially deviated subtalar joint axis, this is altered. So the picture on the right shows a pronated subtalar joint with a medially deviated subtalar joint axis. We continue to have a supination moment with the gastrocnemius loading with the insertion still medial to the subtalar axis into the calcaneus. The pronation moment, due to ground reactive forces at the center of pressure, is still located anterior and lateral to its normal placement. However, the relationship to the subtalar joint axis, now that it's medially deviated, is significantly different. The distance of the center of pressure in the pronated or medially deviated subtalar joint axis is significantly greater to the center of pressure than it is to the supinatory moment created by the gastrocnemius complex insertion into the calcaneus. So if you can imagine drawing a line from this subtalar joint axis to the center of pressure, you can see how much longer that is comparatively to the subtalar axis to the insertion of the gastrocnemius complex into the posterior aspect of the calcaneus. Therefore, this creates a net pronation moment because the center of pressure is a much longer lever arm relationship to the subtalar joint axis comparative to the Achilles tendon. That equals a net pronation moment. In the laterally deviated subtalar joint axis, as you can see in the picture on the right, in a cavus foot or supinated type foot, the axis is almost between the second and third metatarsal heads. The supination moment that occurs from the gastrocnemius complex is lessened because the axis is more in the central aspect of the calcaneus or even slightly medially positioned. And distally, the center of pressure, the ground reactive forces that occur at the center of pressure can either create a pronation or supination moment depending on the relationship of the center of pressure to the subtalar joint axis. Therefore, the relationship to the subtalar joint axis, again, we're looking at the distance of the center of pressure to the subtalar joint axis and the gastrocnemius insertion in relationship to the subtalar joint axis. So if the center of pressure is less than the gastrocnemius, that gives you a net supination moment. If the subtalar joint axis is lateral to the center of pressure, that gives you a supination moment, plus the supination moment that occurs with the gastrocnemius complex insertion into the calcaneus. That gives you a net plus supination moment occurring. This is an example of a patient that has a cavus foot deformity that you will notice getting worse with time, and that's because the subtalar joint axis is creating a supination moment in addition to the supination moment that the gastrocnemius complex loading is causing, and that will increase the cavus deformity over a period of years, and that's where you'll see the patients with a high arch foot developing an even higher arch foot over a period of time. What is the relationship of the medial longitudinal arch and the gastrocnemius complex? What structures stabilize it and what deform the medial longitudinal arch? Thordarson in Clinical Orthopedics in 1995 looked at this question, and they had a study where they looked at the longitudinal medial arch and what supports it and what deforms it in stance phase, and what was the role of the plantar aponeurosis also. They applied plantar loads of 350 newtons and 700 newtons with the ankle joint in 10 degrees plantar flexed with a load of 350 newtons. They measured the angular displacement in the sagittal plane, the talus to the first metatarsal, and the transverse plane, navicula to talus. Continuing from Thordarson, Clinical Orthopedics, 1995, this slide shows a graph that shows the angular displacement in degrees recorded in the sagittal plane between the first metatarsal and talus, with positive values representing arch augmentation and negative values representing arch deformation. Again, there are three measurements that are occurring: 350 newtons applied of force, 700 newtons applied force, and 350 newtons applied force with the foot plantar flexed at 10 degrees. So it's the blue, red, and green lines. With the Achilles tendon, as on the far left, you can see it was the largest deforming force as load was applied to the foot. The highest arch augmentation was by the windlass mechanism, or dorsiflexion of the toes, engaging the plantar fascia. Also, the posterior tibial tendon showed significant arch augmentation, as well as combining the posterior tibial tendon, the flexor digitorum longus, the flexor hallucis longus, and the lateral tendons. Cumulative effect, that is what the PDHL stands for, also showed an arch augmenting effect. And if you really look at this chart, the interesting fact is that even combining all the tendons that come into the foot from the leg, they still did not come near as far as an arch augmenting force as the Achilles deforming force on the medial arch. Continuing Thordarson's article in Clinical Orthopedics 1995, this chart shows the angular displacement in degrees recorded in the transverse plane between the navicula and talus, with positive values representing adduction and negative values representing abduction. Once again, the Achilles tendon is shown to be by far the most significant deforming force on the medial arch and the transverse plane, while the posterior tibial tendon is shown to be the most significant arch recreator in the transverse plane. The windlass mechanism is not significant in the transverse plane as it was in the sagittal plane, and the combination of all the tendons combined also shows a adductive type force versus some of the deforming forces of loading the peroneus longus or brevis tendon causing abduction, offsetting some of the arch adductors. But again, the important concept from the slide is noting the significant deforming force of the Achilles tendon with increasing tension levels. Continuing Thordarson's article in Clinical Orthopedics 1995, the study found that the plantar aponeurosis via dorsiflexion of the toes had the most significant arch supporting function in the sagittal plane. This has been reinforced by Huang et al. In Foot and Ankle in 1993, showing that the plantar fascia has a dynamic arch supporting function. DeLand et al. In Foot and Ankle in 1992 showed they had to divide the plantar fascia and calcaneal navicular ligament to create a flat foot. And Mann et al. In 1993 showed that the plantar aponeurosis is the most significant stabilizer of the arch. So these studies correspond to what Thordarson found in this study. And from their article, Thordarson said, the plantar fascia clearly has an important dynamic function. Dividing the structure should be tempered by this data. So if you're doing plantar fascia releases, you need to consider something else because although it may help with the symptomatology, it comes with consequences. And we'll see this again in other studies, but the traditional method of plantar fascia releases needs to be looked at critically in the future with other types of treatment for the resistant plantar fasciitis cases that do not respond to conservative therapy. Continuing Thordarson et al., Clinical Orthopedics 1995. The posterior tibial tendon was found to have consistent arch supporting function at both load levels 350 newtons and 700 newtons in the sagittal plane. It was also noted to adduct the forefoot in the transverse plane. Simultaneously tensioning the posterior tibialis tendon, flexor digitorum longus tendon, flexor hallucis longus tendon, and peroneus longus tendon was noted to have statistically significant additive arch supporting function when compared to the posterior tibialis alone, suggesting that they all may have a small arch supporting function, but combining them together is really what is important, their functionality as a unit more than individually. Continuing Thordarson article, Clinical Orthopedics 1995, the triceps surae was noted to have a significant arch flattening with a 3.3 degree change in the sagittal plane at 350 newtons and an additional 3.7 flattening at 700 newtons. The Achilles tendon tension was also noted to result in statistically significant abduction in the transverse plane at both of these load levels as well. So the take-home effect is the Achilles tendon is by far the most deforming force on the arch in both the sagittal plane and transverse plane. What are the effects of Equinus on the medial column of the foot? Looking at the first metatarsal, the first cuneiform, the navicula, and the talus. Johnson and Christensen from JAFAS 2005. This is actually a series of articles I'd highly recommend that you look into if you can get a hold of them. They're extremely valuable information that they produce from these studies. There's, I believe, 5 different articles, and they all relate to the medial column of the foot, but this one specifically looks at the role of equinus deformity on the medial arch. They looked at the positional change of the medial column of the foot in close connect chain with variable Achilles tendon tensioning, utilizing cadaver specimens. The Achilles tendon was loaded with tension loads of 0, 30%, 60% of predicted maximum strength during each test trial. The osseous positions and orientations of the medial column bones were collected and analyzed in all 3 cardinal planes. Continuing Johnson and Christensen article from JAFAS 2005. This shows a picture from their article of the midfoot showing that what occurred was frontal plane eversion of the medial cuneiform by the peroneus longus tendon, creating a locking of the mid-tarsal joint. This is from another earlier article in this series looking at the role of the peroneus longus tendon on the medial arch. Basically what it does is it everts the first cuneiform into the central column of the foot and lateral column of the foot, helping to stabilize or lock the mid-tarsal joint. So that was the role of the peroneus longus as depicted by this picture. Continuing Johnson and Christensen, JAFAS 2005. What they noted was as they increased Achilles tendon loading, they saw a dampening of the function of the peroneus longus. which resulted in less eversion of that medial cuneiform into the central column and lateral column of the foot, which resulted in unlocking of the mid-tarsal joint, which created a hypermobility of the first ray, which led to arch flattening in the sagittal plane, particularly at the navicular cuneiform joint. And what they noted specifically with each bone is they showed plantar flexion of the talus and navicula with dorsiflexion of the first cuneiform and first metatarsal. Continuing Johnson and Christensen in JAFAS 2005. In clinical practice, the early destructive influence of Equinus is often not appreciated. Instead, we are usually faced with the end result of Equinus effects. The authors strongly recommend careful clinical assessment and appropriate treatment of Equinus in patients with biomechanical deformities affecting the first ray and midfoot. Continuing Johnson and Christensen, JFAS 2005, our findings support that the concept that treatment of Equinus can slow the development of hallux abductor valgus by reducing first ray hypermobility and allowing peroneus longus to function more effectively. Failure of various arch stabilizing procedures and bunion corrections can often be attributed to untreated Equinus deformity. And finally, likewise, failure to address an Equinus deformity may explain persistent arch symptoms in patients after plantar fascial release for plantar fasciitis. So not only if you have Equinus in a patient with plantar fasciitis, which is of course very common, if you go in and release the plantar fascia, you're going to destabilize the arch, and you still have an arch deforming effect of the Equinus deformity onto the foot. It's going to exacerbate this problem. So again, tread lightly with plantar fascial releases, and if you are going to do them, definitely consider addressing the Equinus deformity to try to reduce the amount of deformation of the arch by an untreated Equinus in a foot that's already been weakened by a plantar fascial release. What are the effects of Equinus on peak plantar pressures? Aronow et al. In Foot and Ankle 2006. In their study, the purpose was to test the hypothesis that both isolated gastrocnemius and combined gastrocnemius and soleus triceps surae contractures would transfer weight-bearing load from the hindfoot to the midfoot and forefoot as determined through changes in plantar pressure distributions. In addition, they hypothesized that the effect would be similar independent of the location of the applied force, either through the gastrocnemius, the soleus, or a combination of the two. Continue Aronow et al. Foot and Ankle 2006. They looked at 10 cadaver samples. They loaded it to 79 pounds of plantar force, which is 350 newtons. The foot was then placed in unconstrained on a 10-degree dorsiflex plate, and then combinations of static gastrocnemius or soleus forces were applied in 3-pound increments. The plantar pressures using F-scan were taken for the forefoot, the midfoot, and the hindfoot. This shows a graph of their findings as they applied 0 pounds, 21 pounds for the triceps surae, 0 pounds, and 18 pounds for the gastrocnemius. The pressure for the triceps surae in the forefoot went from 17.60% at 0 pounds to 27.95% at 21 pounds of pressure. And for the gastroc went from 18.80% at 0 pounds of pressure to 28.10% of 18 pounds of pressure. The midfoot measurements for the triceps surae at 0 pounds of pressure went from 7.30% to 10.05%. And for the gastroc at 0 pounds went from 7.60% to 18 pounds of pressure at 10%. The triceps surae at 0 pounds were originally at 75.10% and decreased to 61.95%. And the gastroc at 0 pounds of tension went from 73.60% to 61.80%. So what this slide is showing that as tension was applied to either the triceps surae or the gastrocnemius, an increasing amount of pressure went from the heel to the ball of the foot and the midfoot. Basically, the amount of decrease in pressure in the heel resulted into an equal amount of increase in the midfoot and forefoot. Continuing Aronow et al. Foot and Ankle 2006, increasing triceps surae force from 0 to 21 pounds, 93 newtons, increased an average percent of forefoot and midfoot force by 59 and 38% respectively, and reduced the average percent of hindfoot force by 18%. Increasing the gastrocnemius force from 0 to 18 pounds increased the average percent forefoot and midfoot force 50 and 32% respectively, and reduced the average percent of force on the hind foot by 16%. Aronow et al., Foot and Ankle, 2006. These results were similar to other pressure studies by Jones, 1941, and Ward, 1998. They demonstrated statistically significant difference with a much smaller change in only 3-pound increments totaling 21 pounds in total triceps surae force. This is more applicable to those with subtle biomechanical changes compared to the more severe toe walking or neurological type equinus deformities. And Mueller et al. And JBDS in 2003 looked at tendo-Achilles lengthening for diabetic patients with forefoot ulcers and showed decrease in forefoot pressures by 31% and increase in heel pressures by 34% after a tendo-Achilles lengthening, which corresponds to the findings that Aronow et al. Found in this study. As they decreased triceps surae forces in Aronow study from 21 back down to 0, the forefoot pressures decreased by 32% and the heel pressures decreased by 31%. And you can see the similarities between this study and Mueller's study by doing the TAL for the diabetic patients. Those numbers are very similar and very reproducible from two different studies, which is always reassuring. Aronow et al., Foot and Ankle, 2006. Conclusions. In a static model, increased triceps surae or isolated gastrocnemius force shifted weight-bearing plantar pressure from the hind foot to the midfoot and forefoot. Similar results were noted whether the triceps surae force was applied through the gastrocnemius or soleus or both. Continuing with their conclusions, the similar effects with triceps surae force application through the gastrocnemius or soleus suggest that patients with isolated gastrocnemius contractures may obtain similar clinical benefits with potentially less morbidity after gastrocnemius aponeurosis lengthening as compared to tendo-Achilles lengthening. So what they're showing is we may not actually need to do a tendo-Achilles lengthening on some of these patients with diabetic foot ulcers or other problems, that actually the gastrocnemius aponeurosis lengthening may be as effective. What is the effect of equinus on joint angle and joint work? Yu et al. In Clinical Biomechanics at 2009 looked at the effect of the gastrocnemius tightness on joint angle and work during walking in order to better understand the compensatory movement patterns, which are important for designing effective interventions and preventing injury and disabilities. Yu et al., Clinical Biomechanics, 2009. In their study design, they had 44 participants with a mean age of 22.9 years of age, and they had an equinus group and control group with 22 patients in each group. Their equinus group was ankle joint dorsiflexion less than 12 degrees with the knee extended. Again, you can see the variation in definition amongst different studies even, and trying to get a definition that is standard would be very beneficial. Their control group had ankle joint dorsiflexion with greater than 15 degrees with the knee extended. The control groups were also gender matched. They were measured in the prone position with the subtalar joint in neutral, utilizing a goniometer. They also used gait analysis, 3D camera system, and force plates. They looked at the rate of steps, 100 steps per minute, 140 steps per minute, utilizing a metronome to help set the pace. The average adult cadence is noted to be between 100 and 120 steps per minute, according to Inman's study, so that's where they used that pace from. The results, height and weight were not statistically significant between the groups. The mean ankle joint dorsiflexion with knee extended was statistically significant between the groups, 9.0 degrees to 18.7 degrees. The mean ankle joint dorsiflexion with the knee flexed was not statistically significant between groups. That's why I don't pay very much attention to ankle joint dorsiflexion with the knee flexed. I think the vast majority of the problems are gastroc related, so I really pay much more attention to the measurement with the knee extended. Gait performance in this study was primarily due to gastrocnemius muscle function. That was sort of the take-home message with this study too. Continuing, Yu et al. Clinical Biomechanics, 2009. Gastroc equinus showed greater hip and knee flexion angles at the time of maximal ankle joint dorsiflexion. There was less knee work generation and greater ankle work absorption. Also noted was faster cadence was associated with greater work generation at all joints, greater work absorption at the knee, and less work absorption at the ankle. This is from their study showing the equinus group at 100 steps per minute and the equinus group at 140 steps per minute. then the control group at 100 steps per minute, and the control group at 140 steps per minute, and then the p-value for the comparisons. They looked at the joint ankle with the ankle joint maximum dorsiflexion, so they looked at the hip, knee, and ankle. They looked at the joint work generation for the hip, knee, and ankle, and then they looked at the joint work absorption for the hip, knee, and ankle. The areas that are highlighted or darker are statistically significant. So for the joint angle for ankle joint maximal dorsiflexion for the hip and knee were shown to be statistically significant. The knee showed statistically significant joint work generation, and then joint work absorption was noted to be significant for the ankle. Positive values represent the joint flexion at the hip and knee and dorsiflexion at the ankle. Negative values represent joint extension at the hip and knee and plantar flexion at the ankle. But this as a summary of the prior slide's findings. Continuing Yu et al. Clinical Biomechanics 2009. Interpretation: the subjects with gastrocnemius tightness revealed a compensatory gait pattern, which included the changes in joint angles and associated work productions. The potential disturbance of the knee control and strain injuries of the plantar flexors might be crucial in the clinical considerations for subjects with gastrocnemius tightness. Proximal and distal compensations occur with Equinus. The relationship with the subtalar joint axis and center of pressure determine the effect of Equinus on the foot. The Achilles tendon has significant arch flattening effect on the foot in the sagittal and transverse planes. Increased loads on the Achilles tendon dampens the effect of the peroneus longus tendon, resulting in mid-tarsal joint instability and flattening of the arch at the navicular-cuneiform joint. This creates an opposing force to orthotics trying to stabilize the medial arch and can lead to poor orthotic tolerance. Equinus results in compensation consisting of increased flexion of the hip, knee, and increased work absorption of the ankle joint, and less knee work generation during stance. Any questions, please feel free to email me at padehere@sbcglobal.net. Thank you.